Thank you for inviting me for this presentation. I have no financial disclosure of any sort. So I'm going to take you through a few cases of PED, and then we'll talk about the treatment options and take-home message. So this first case was a 78-year-old Caucasian male who had a history of wet AMD in the right eye and presented with the loss of vision with counting finger in the left eye. He had optic nerve druseness in both eyes and at the time of presentation for the left eye, his right macula was stable post-injection. He had ranibizumab Lucentis injection for a year prior to the presentation, and PED in the left, at the time of the presentation, he had a pigment epithelial detachment, PED, in the left eye with some subretinal blood. As you can see in the fluorescein angiogram, there was a PED with CNV. Due to provincial coverage, we had to use bevacizumab, which is Avastin, in the left eye, due to the vision guidelines with the provincial coverage. So in this OCT, you can see there is a nice PED with intraretinal fluid and a little subretinal fluid. And just after one injection of bevacizumab Avastin, it regressed with some RP changes, and the PED resolved after one injection. So, wow, what a response. Like, the right eye required treatment for 1 year, and left eye just one shot. OCT changes in the right eye were less pronounced than the left eye, though left eye required shorter treatment, even though structural and vision loss were significantly higher than the right eye. In case 2 of this pleasant 73-year-old woman with history of distorted vision with 20/30 vision in the left eye, the fundus picture showed subretinal blood with subretinal fluid and pigment epithelial detachment in the left eye. Fluorescein angiogram confirmed the CNV, and anti-VEGF was discussed. As I mentioned earlier, due to the guidelines at that point, she was ineligible for provincial coverage. So we talked about both ranibizumab and bevacizumab, Lucentis and Avastin, and patient chose Avastin due to the cost. So you can see in this picture the subretinal blood, subretinal fluid, and angiogram results. The OCT showed that there was a subretinal fluid with PED, which resolved with the treatment, but that PED stayed there. So the subretinal fluid and subretinal blood resolved with the treatment. Shallow PED post-injection. Why PED did not go away? The third case, 62-year-old Caucasian female with wet macular degeneration in the left eye, and the vision was 20/20 in the right, 20/30 in the left. At the time of presentation in the left, it was subretinal blood with scar. Anti-VEGF therapy was discussed, both Lucentis and Avastin, and patient was covered with Lucentis. So we used the Lucentis. With Lucentis, the scar decreased, and it's only present at the outermost edge of initial scar, and she maintained vision of 20/30. You can see a big scar with the blood, and FA showed the CNV activity with block fluorescence related to the hemorrhage, and OCT scan showed improvement with stability of vision, but still residual PED and some scar tissue. 9 months post-injection in the other eye, because it was monthly injections and we were still watching the right eye, there was SRB noted temporal macula with vision of 2025. Patient wasn't symptomatic. It was found on just monthly follow-ups. So the anti-VEGF was discussed again, and she was again covered for Lucentis, so we used it. and she maintained vision in both eyes with monthly injections, and vision was in the right eye 2025 and left eye 2030. 9 months post-injection in the right eye, the right macula, even with monthly injections, got worse. And there was a significant blood, and vision went down to 2400. And treatment option discussed: continue versus macular surgical treatment, and patient chose to hold off surgical intervention. These are the findings. You can see in the on the middle section of the OCT that scar tissue regressed as time went by after the bleed. The subretinal blood resolved in both eyes. Scar tissue continues to shrink. Vision after a big bleed in the right eye is stable at 20/50 and left eye is 20/30. We are continuing with Lucentis to prevent the further vision loss, trying to extend the interval between 2 injections. So going forward to the fourth case, 81-year-old patient, 20/100 vision, FA showed PED. We discussed VEGF versus PDT and risk of RIP with the PDT. You can see PED there on the fluorescein, and the OCT showed in the first part, March 2012, to 20/100, and big PED with subretinal blood. With treatment, it decreased in the size, the PED size, as well as subretinal fluid regressed. Over the time of 2 years, the subretinal fluid went up and down. We tried to increase the duration between 2 injections, and in 2014 it was like 20/30, with some still at that point. The last Lucentis injection was still subretinal blood with lesser PED. So the PED was smaller than March 2012. Options were continue current treatment, PRN, or stop the treatment. And there were risks with stopping the treatment or switching to Avastin due to tachyphylexis, or switching to PDT. Is it a success? Patient was happy with it because visually she was seeing better. Structurally, it was better than before, but not perfect. And the last case, the 71-year-old Caucasian male with history of dry AMD presented with 2200 vision, and angiogram and ICG confirmed CNV with PED. He was again covered with the provincial coverage for Lucentis, and we reviewed the other option of PDT and RPE tear, RPE rip, considering the size of PED. So you can see in 2010 he had a dry AMD. In 2011 January he had subretinal fluid with PED, and the angiogram and ICG confirmed PED with CNV underneath. And in this OCT you can see the big PED with intraretinal fluid and subretinal fluid. So post-injection, PED decreased to 20/150, and post-third injection it was 20/80. And November 2011 it was 20/60, and in November 2011 we repeated FA and ICG again, and there was no polypoidal. So we reviewed again the choices and decided to continue with the Lucentis injections. 4 years later, vision was 20/60, shallow PED. So you can see that day 0, 1 month, the PED size decreased. And 4 years later, size was way less, but not perfect resolution. And so that's the OCT scan. of the 4 years later, the PED is smaller. So patient was very satisfied with the current vision. Reality was there was still residual shallow PED. My desire was a flat macula. So we tried to extend, and the SRF will increase if we extend the follow-up. So will we stop the treatment? Will we ever get rid of that gap? Will PDT help? Will PDT cause rip or tear? Should we try Avastin to see if tachyphylexis is the cause for non-resolution of this PED? With the Avastin, the patient was not sure because of the off-label use. So then came aflibercept, and I thought about should we try it, and we did. And these cases are outside the study for aflibercept. So day 0, aflibercept, you can see that there was a residual PED. Month 1, it decreased by almost half the size. Month 2, it decreased by 1/3. And month 3, it's almost gone, except you can see a wedge or like a slit underneath. And month 4, it was flat. So 4 aflibercept injections versus 4 years of treatment with Lucentis. So should we try the aflibercept in other cases? So I did try in the case 4, and you can see that the subretinal fluid, which was around the edge of the PED, decreased. She had some medical issues, and she couldn't come for 4 months after starting aflibercept injection. So she had a break for 4 months. So you can see in the last OCT image, there was a worsening of subretinal fluid. And we treated it again, and a month later, it significantly decreased in the second picture of the OCT. And later on, it has been stable. The PED size has gone down a bit, but not completely. So a quick review of theories around AMD. The senescence theory, which means that laminar deposits causes local vessel damage, which leads to hypoxia, and CNV formation, which leads to abnormality in choroidal perfusion. Vascular theory, one theory suggests that it's a loss of choroidal vessels, which leads to hypoxia and CNV, versus other vascular theory suggests that there is a scleral stiffening and compression of vortex veins causes increased choriocapillaries fluid filtration and CNV. Versus loss of choroidal vessels, which leads to choroidal hypertension, choriocapillaries hypertension, and increased choriocapillaries fluid filtration and hypoxia. A little complex slide suggesting the same with different factors, including interleukin, as you can see in this slide, as one of the causative factors, as well as metallo MCP, protease, and the complement factors. So all these factors leads to increase in the VEGF level, which is we all know vascular endothelial growth factor. And what are the theories around the PED, the pigment epithelial detachment? One, Dr. Bird et al. Suggested that its Brooks membrane becomes more hydrophobic with age. Chen et al. Suggested that it's a decreased conductivity of Brooks membrane, loss of scotopic sensitivity. Polikov suggested that it's a decreased conductivity of Brooks membrane and decreased choroidal perfusion. And as we know, all the milestones in the treatment, which started with laser photocoagulation to PDT and the Visudyne PDT, that part of the era didn't do a lot about vision. The next part was Avastin and Macugen, which was Avastin was off-label, and Lucentis was developed and then the Eylea or aflibercept.
CHIRAG, may I request you to...
So we'll skip that, and then we know all the pharmacokinetics of it. Some papers suggested that the aflibercept helps with the resolution of PED, and one key note or one take-home message is PEDs with hyperreflective are more responsive than hyperreflective PEDs, and that might be because of how hyperreflective is with the VEGF-driven vasodilation, and hyperreflective is mixed and solid PEDs. The answer is Avastin better than Lucentis versus Eylea? There's no one better than others, but definitely Eylea worked better. There is always a consideration for tachyphylaxis. Should we consider to switch? Should we consider to give a break for a while? All those factors are, depends on the cases and the future target at the resolving the issues. Thank you very much.